Hello, I am Martin Lederman, co-founder of the organization One World, One Vision. Over a decade ago, my associate and I, while on a surgical mission to Belize, founded One World, One Vision in order to train local ophthalmologists and, by doing this, extend our reach. We were successful, and since then, our organization has gone to multiple countries and have demonstrated the success of our ideas. We added anesthesiologists and pediatric intensivists to the mission in order to train local physicians and make the surgical experience of our patients safer. Since then, we have realized that the paradigm of one patient, one student, and one surgeon, while successful, could not begin to address the need. There are tens of millions of children and adults with strabismus and amblyopia. We decided, therefore, to support and to promote a video course in strabismus and amblyopia and approached Dr. Bert Kushner to develop a curriculum and to recruit worldwide experts to give lectures. We stipulated that the course should be translated into multiple languages and to be distributed without cost around the world to eye surgeons. We are particularly grateful to our former patients and friends who have given the financial support to make our dream a reality. We are delighted that Dr. Kushner has accepted the challenge, and we hope you find the lectures both stimulating and educational, and that you share them with your colleagues and your students. And so, without further ado, I give you Dr. Bert Kushner.
Welcome, viewers, to this One World, One Vision comprehensive course on strabismus and today's lecture on paralytic strabismus. If you viewed other lectures in this series, I want to welcome you back. If this is your first time viewing, I'm glad you're here. And today it's a real pleasure to introduce our speaker, Dr. Gena Heidary from Harvard. Dr. Heidary is an associate professor at Harvard Medical School, where she's the founder and director of the Pediatric Neuro-Ophthalmology service at Boston Children's Hospital. She's the director of Pediatric Ophthalmology and Strabismus Fellowship Program at Boston Children's Hospital, which I would parenthetically say is probably one of the very best in the country, if not in the world. Dr. Heidary got her MD and PhD in neuroscience from the University of Pennsylvania School of Medicine, followed by a residency at Harvard Medical School, and then a fellowship in pediatric ophthalmology and strabismus at Boston Children's Hospital. Subsequently, she did a second fellowship in neuro-ophthalmology at the Massachusetts Eye and Ear Infirmary, and she became the first dually fellowship-trained pediatric neuro-ophthalmologist at Harvard. Dr. Heidary spearheaded the development and writing of the first case-based textbook in pediatric neuro-ophthalmology, titled Fundamentals in Pediatric Neuro-Ophthalmology, and it was just published this past summer by Springer Press. She has over 48 peer-reviewed publications, 30 reviews and textbook chapters, and made major contributions to two textbooks, the one I just mentioned, and another, Learning Strabismus Surgery. She has received numerous awards from AAPOS, the AAO, and Harvard. And Dr. Heidary has been honored as being listed in Boston's top doctors multiple times, as well as the regional top doctor competition. So with that in mind, it is truly a pleasure for me to turn this over to Dr. Heidary.
Thank you, Dr. Kushner, for such a wonderful and kind introduction. I'm so honored and very excited to be part of this project. Today, I'll be talking about paralytic strabismus. We'll be considering surgical approach to third nerve palsy, sixth nerve palsy, and some considerations in fourth nerve palsy. I have no relevant financial disclosures. So let us begin by thinking about third nerve palsies. I always like to frame a discussion by presenting a case. I think this really helps us to dig more deeply into our surgical thinking and surgical approach. This is a 4-year-old boy who presented to me with exotropia, hypotropia, and amblyopia of his right eye, secondary to an already diagnosed congenital third nerve palsy. You can see here that in his right eye, he was mildly amblyopic, 20/50 in his right eye, 20/30 in his left eye. And he had anisocoria. Interestingly, his affected side was more myotic. And I wonder if this was a form of aberrant regeneration. These are his external photos. In primary gaze, he has right exotropia and hypotropia. You can see that in left gaze, he has limited adduction of the right eye. So he can't really even adduct his right eye past the midline or even to the midline. In elevation and infraduction, he has limited mobility, and you can also see his ptosis. So this is a patient with an oculomotor palsy with complete paralysis of the medial rectus muscle and limited elevation and infraduction of the right eye. So the parents had come for consideration of treatment options, surgical treatment options. Before we get to what I did for this patient, I wanted to review the different etiologies that can contribute to a third nerve palsy. One of the most frequent etiologies we'll see in children will be a congenital third nerve palsy. We see in pediatric patients and in adults trauma that can lead to a third nerve palsy. We may see patients who harbor a tumor along the third cranial nerve. In pediatric patients, we may see this in the setting of neurofibromatosis type 2 as schwannomas, both in kids and adults. We think of aneurysms causing a third nerve palsy more commonly in adults, but it's very important to recognize that aneurysms may also occur in children. Patients who have had injury or manipulation of the brainstem may also have third nerve palsy. This might be from surgical tumor debulking or an infarction, for example. In pediatric patients, we're not typically considering a vasculopathic etiology, but in adults, it's important to think about diabetes and hypertension as risk factors for developing a third nerve palsy. There are other less common etiologies, inflammatory, infectious. Children who have ophthalmoplegic migraine, most frequently, this migraine may result in a third nerve palsy followed by a sixth nerve palsy. And it's very important in our adult patients, when relevant, to consider giant cell vasculitis presenting as a third. So before we get to surgical management, it's important for us to carefully evaluate the patient and look for underlying etiology. In the acute setting, an acute presentation, when we know this is not a congenital third, we want to obtain imaging of the entire pathway of the third cranial nerve. And this should be done with and without contrast, so we can look at any inflammatory or infectious processes that may not be highlighted in a non-contrast scan. Because children and adults can get aneurysm, we want to do some imaging of the vasculature, and this can be an MR angiogram or a CTA of the head to assess for aneurysm. Then further consideration in collaboration with often neurology is performed. We may do a lumbar puncture. In pediatric patients, when our patients present with a third nerve palsy that we believe is congenital, we've recognized that some of these patients may actually have congenital fibrosis of the extraocular muscles, and therefore send our children for genetic testing before we conclude that this is idiopathic congenital third. When the pupil is not involved, we may consider mimickers of a third nerve palsy, such as myasthenia gravis or even thyroid eye disease. And finally, in adults, when we think about this ischemic third, it's really important to send our adult patients for further testing with their primary care providers to look at risk factors such as hypertension and diabetes and hypercholesterolemia. In this patient, I chose to perform a procedure that we'll spend some time discussing, which involved transposing the split lateral rectus muscle nasally towards the medial rectus muscle. I performed this surgery and included a superior oblique tenotomy as well as an inferior oblique myectomy to facilitate the movement of the muscle underneath the rectus muscles. This is an image that comes from the AAO website that talks about this procedure. In the middle panel on your slide, you'll see that the lateral rectus has been split in half. This is the left eye we're looking at. And there's suture that has been locked and imbricated on the superior half and the inferior half of the lateral rectus muscle. These sutures then are passed underneath the superior rectus and inferior rectus muscles, respectively. And in the panel all the way to the right on your slide, you see that the suture has been passed underneath the superior inferior rectus muscles, and the lateral rectus is now being pulled towards the medial rectus. So it's really like the lateral rectus is now hugging the globe still and in a more appropriate primary position, orthophoric position. And I was very pleased with the results in this patient. You can see immediately postoperatively that the patient had small exophoria, or mainly was orthophoric. Of course, this procedure was not intended to address the hypotropia. And 4 years later, he is quite stable in his postoperative alignment. So let's think more broadly about how we might approach surgical management when we're really thinking of the exotropia, the horizontal component of this condition. And I think the surgical approach really depends on the degree of medial rectus function. So is there paresis? In other words, is there some adduction remaining or complete paralysis of the medial rectus? And I find in children it's easiest to assess this by looking at kind of the saccades that are generated, the velocity of the saccades, whether the patient is able to pass midline. In cooperative adults, we might be able to assess this using forced duction testing or even forced generation, but I find in children it's harder to accomplish this. When we have paresis of the medial rectus muscle, we'll consider a unilateral recess-resect procedure. And then when there's paralysis of the medial rectus, in truth, there are many different ways of approaching this. And I think that this is one of the most difficult types of paralytic strabismus to treat effectively, because it really is difficult to overcome this complete paralysis of the medial rectus. In the past, my favored surgical approach when the superior oblique is not involved, so in other words, when there's an isolated third nerve palsy, I prefer to transpose the superior oblique nasally. I couple it with a mechanical restriction by resecting the medial rectus muscle, even though it's paralyzed, and performing some procedure that inactivates the lateral rectus. So I've done this by fixating the lateral rectus to the periosteum, and others have suggested that extirpation of the lateral rectus muscle may be an effective way of completely inactivating the lateral rectus. The nasal transposition of the split lateral rectus muscle I've performed in a very specific type of patient. So this was a patient who not had prior surgery, where our goal in this case was primarily reconstructive, and where the family was amenable to a procedure that has with it some risk. Others have proposed fixation of the globe to the medial orbital wall through a flap. Newer techniques might include actually foreshortening the conjunctiva to create, again, a mechanical restriction to tether the eye to orthophoric position. And we'll talk a little bit about the Nishida procedure for 6 nerve palsy. And I've heard some colleagues using this to try to address third nerve palsy as well. What I'd like to focus on is some of the work that's been performed by my colleagues at Boston Children's Hospital, really led by Doctors Linda Doggy, Ankur Shah, Isdin Oke, and that kind of builds upon some of the work of Dr. Birsen Gyokit and others in the international community who have performed this procedure. Dr. Doggy has led an international registry to really collate the data of how this surgical approach addresses third nerve palsy. And I think this is something that we can recapitulate with other types of surgical techniques. This is something that was valuable because most of us as surgeons probably don't perform this procedure that frequently, and it would be valuable by pooling all this information together to understand what are the outcomes, what are the complications. So this paper that I'm discussing reflects on the results from the international registry that really covered data from North America, South America, Europe, the Middle East, and Asia, where they were looking at the results of this procedure in those patients who had unilateral third nerve palsy. There are other papers from our group looking at bilateral third nerve palsy, but these data are the most recent. So this cohort included pediatric and adult patients with unilateral third nerve palsy and at least 6 months follow-up. The most common etiology in this cohort was congenital third nerve palsy. And the surgical goal here was motor alignment within 15 prism diopters of primary position. In terms of overall outcomes, 69% of patients had successful motor alignment as defined by the authors. And when superior oblique tenotomy was included as part of the surgical procedure, that subset of patients had 100% of success. I was surprised to find that a third of patients also had fusion, which I find very encouraging. To me, this is the most important piece to take away from this procedure, which is how do we approach it? Who is the appropriate patient? And what were some of the technical difficulties and complications of this procedure? So with respect to the technical difficulties, the authors have found that when there's previous surgery on the lateral rectus muscle, the muscle already is tight and shorter, it's quite difficult to split the muscle and bring it all the way around to the medial rectus. And it's probably not the ideal patient to try this technique in. Other surgeons reported that split in two, pulled in two of the lateral rectus muscle, that sometimes one arm of the lateral rectus was easier to pull around than the other. And this procedure is associated with some potentially vision-threatening complications, including choroidal effusions, anterior segment ischemia, and even optic nerve edema. So one of the important outcomes of this international registry was a recognition that when the lateral rectus is pulled around towards the medial rectus insertion, if the lateral rectus is within 4.25 millimeters or closer to the medial rectus insertion, in other words, more anterior, the risk for some of these complications was very low. In those who reported in the registry a more posterior placement of the lateral rectus muscle, this was fraught with complication. So I think this is one of the most important points that have come out of all of the papers regarding this international registry. So to summarize, in truth, there are numerous surgical approaches, really with varied success. There hasn't been a prospective study to really carefully delineate what would be the appropriate procedure. And you have to kind of take into account, has there been prior surgery? What are the surgical goals? And then address this appropriately. So we'll now move on to 6 nerve palsy and our surgical considerations therein. This was a 12-year-old boy who presented to me. You see that he has a tumor involving the brainstem area. He has a clival chordoma. And after resection of this tumor involving the clivus, he developed a 6 nerve palsy. His afferent function was totally fine. And in this external photograph, series of external photographs, you see in primary position, he has a left esotropia. When he looks in left gaze, he cannot abduct past the midline, but in other fields of gaze, his motility was otherwise fine. And in this case, his esotropia was so large that he could not even adopt a left head turn to try to retain fusion. and eliminate diplopia. So he has a complete sixth nerve palsy. He's symptomatic with diplopia, and the goal is a surgical correction for him to eliminate his diplopia. When we think about etiologies in sixth nerve palsy, we need to think about conditions that may involve the pons or the brainstem, so pontine glioma. We have patients who have elevated intracranial pressure who present with a sixth nerve palsy. Of course, many of us have seen trauma that has led to sixth nerve palsy, tumor along the pathway of the nerve. And I see a lot of children who have posterior fossa tumors. And often we find that postoperatively, patients will develop a sixth nerve palsy, so an iatrogenic sixth. We can see this in inflammatory or infectious conditions. This can even occur after virus. There are data that suggest that you can develop a sixth nerve palsy after particular vaccinations, specifically the flu. And this is a less common manifestation of ophthalmoplegic migraine in children. Similar to what we mentioned for third nerve palsy, when we're thinking about that ischemic sixth in adult patients, we, like a diabetic or a hypertensive sixth, we want to ensure that they have proper workup and also assessment for those risk factors, such as hypertension and diabetes. When a sixth nerve palsy presents to me, I obtain MRI of the brain in orbits, again, with and without contrast, to really carefully delineate the sixth nerve along its entire pathway. In all of these situations, we often ask for thin cuts through the brainstem so we really can carefully see the nerves. In children, some of our children with elevated intracranial pressure may have this secondary to processes that impact the venous sinus drainage, such as in mastoiditis, that then causes dural sinus thrombosis. And so in certain circumstances, we might get MRV of the head. We'll partner with our neurology colleagues to get lumbar puncture when relevant to assess the intracranial pressure and also for any CNS inflammation or infection. In our neck of the woods here in Boston, we're often seeing Lyme-associated findings, particularly in summertime, so we send for Lyme serologies. And similarly, we want to look for mimickers, such as myasthenia gravis, or thyroid eye disease, or giant cell arteritis in the relevant population. When we see this ischemic sixth, there is literature to suggest still to perform neuroimaging before making the conclusion that this is a hypertensive or diabetic sixth in adult patients. So I'm going to briefly talk about a procedure that we do quite frequently here at Boston Children's Hospital for the treatment of sixth nerve palsy as well as for Duane syndrome, and then some of the recent modifications to this technique, as well as newer considerations for surgical management. For this young man, I did what our group began describing in 2012, and which many of us have adopted as our primary go-to treatment when the abduction is really paralyzed, which is to perform a superior rectus transposition to the lateral rectus. In this case, performed with a loop myopexy attaching the superior and lateral rectus muscles, coupled with medial rectus recession. So this is what was originally described by our group in 2012. In my experience since that time, what I've found is that in sixth nerve palsy, quite often the lateral rectus is really flaccid. So I have found the loop myopexy to be less successful for me in creating the tension that I want. And I often do the superior rectus transposition with a suture to the sclera or Foster augmentation suture rather than the loop myopexy. In my opinion, I think the loop myopexy is more effective in Duane syndrome when that lateral rectus quite often has a lot of tension and is quite taut. So then you get that effect that you want with loop myopexy. And I think that this patient did quite well. He has a just small residual esotropia, which he can use a very tiny head turn to eliminate all diplopia. So when we consider the management of sixth nerve palsy, I think it's similar to what we talked about for horizontal part of the third nerve palsy? Is there partial impairment or paralysis of the abducting force of the lateral rectus? And again, we can assess this by sort of this velocity of saccades, force ductions, and force generation. When we see partial abducens palsy, I usually do a recess-resect procedure. Sometimes you can add recession of the contralateral medial rectus muscle. And in some ways, that's really good because when you recess the medial rectus muscle on the unaffected side, you reduce the concomitants in lateral gaze from the affected side. So I think that can be quite successful, but often we don't really need to go that far because the esotropia is not quite as large. There are many approaches that have been described with complete abducens palsy. I think our audience is very familiar with vertical rectus transposition of the superior and inferior rectus muscles. This sometimes has been described in association with botulinum toxin to the medial rectus muscle in order to kind of relax that restriction of the medial rectus. Our group started doing single vertical rectus transposition with medial rectus recession with the advantage that it is true that over time the medial rectus can become more taut. And so doing a recession and relaxing that tension, I think, is an important part of allowing the eye to move more freely. And then we'll spend a moment talking about the Nishida procedure. One of the things that is important to consider is what is the appropriate time for surgery? And I think there are some data that came out of really early studies by Jonathan Holmes that laid the foundation for the Pediatric Eye Disease Investigator Group. So this is on the cusp of the development of PDIG, the harbinger of PDIG, several prospective studies looking at the natural history of traumatic sixth nerve palsy. So in the first study, they looked at spontaneous recovery 6 months after traumatic sixth in 33 patients, and they found that 73% of these patients actually had improvement or resolution of sixth nerve palsy. When the group looked at what were the risk factors for poor recovery, they identified two. One was evidence of basically -4 abduction or limitation of ability to get to the midline at presentation, and also bilateral involvement. And I think in practice, we use this idea of waiting at least 6 months before we pursue surgery because there's a potential for spontaneous recovery. The other thing I would say, I use this for a couple of other scenarios, even though these scenarios were not really studied in the Holmes article. So one scenario is in the setting of that iatrogenic sixth that I discussed after posterior fossa tumor resection, and in our patient with the clival chordoma. So I often say, look, we need at least 6 months for us to know whether there's going to be improvement in the abducting ability of the lateral rectus muscle after this type of procedure. One of the nuances here that I think my practice has varied from earlier on to now is that quite often if I saw patients in the acute setting after sixth nerve palsy onset, about 6 weeks into it, if I saw them at that time, I often offered Botox injection to the medial rectus muscle to try to avoid restriction that may impair that full movement. And it really depends on the timing of when patients present, because now often I'm seeing patients after sort of well out of that window of time. And so I don't always offer Botox to kind of bridge us to see whether or not the sixth nerve recovers. So this was the original, these were the data from that original paper from Reshma Mehendal and colleagues at Boston Children's Hospital. She looked at 17 patients, 10 of whom had Duane syndrome, 7 patients had a sixth nerve palsy, and they found that the mean reduction in esotropia using this superior rectus transposition with medial rectus recession was approximately 30 prism diopters. I remember this quite vividly at APOS when this paper was presented as a platform presentation, that one of the questions or critiques was, whether or not this surgery would create intorsion because you're just transposing the superior rectus muscle, and whether or not the unilateral transposition or the single vertical muscle transposition would create new vertical misalignments. So now we have some data to answer those questions that were raised so many years ago at APOS. This was an interesting article that relates to my comment earlier about the loop myopexy versus Foster augmentation. This was done by colleagues and published in Journal of APOS, a retrospective study of 15 eyes in which they used the Foster augmentation suture technique instead of loop myopexy, and found that a couple of things: that superior rectus transposition alone corrects approximately 15 prism diopters of esotropia. And these authors provided this table, which I find to be quite helpful in thinking about how much medial rectus muscle recession to do in addition to the superior rectus transposition with Foster augmentation, depending on, esotropia and primary position. So this gives you some gauge of how much medial rectus surgery to do. In my experience doing this, I typically put the medial rectus muscle on an adjustable suture, even in our pediatric patients. So I find that I have a little more flexibility assessing the outcome because I can adjust it either way if I'm over or under. And my colleagues, Dr. Velez, Chang, and Pinellas, did a different study, which I found interesting, looking at, instead of transposing the superior rectus, considering the transposition of the inferior rectus muscle when there are certain preoperative vertical misalignments that would favor doing the inferior rectus. And they found that this was quite successful and similarly successful to superior rectus transposition. So this is a study that I participated in with my colleagues, looking now it's been, so the first study from our group came out in 2012. This study came out in 2020, looking at our long-term follow-up of patients who've had the superior rectus transposition with medial rectus recession, and to specifically address the question that was raised so many years ago about inducing vertical misalignments and inducing torsion postoperatively. In what we found, there was no patient with symptomatic torsion, but there were in the cohort 7.5% of patients with symptomatic vertical diplopia, of whom 6 required surgical treatment. And this figure shows 3 bars. The one on the left-hand side, the pre-op hypotropia, shows that what we want to do is focus on the orange part. So the orange is that there was no postoperative vertical deviation. So interestingly, if you look at pre-op hypotropia, there were 3 patients who started off slightly hypotropic, and then after superior rectus transposition, this resolved. And similarly, if we look at the bar all the way on the right-hand side, pre-op hypertropia, there were 10 with preoperative hypertropia who then had no postoperative vertical deviation. And then of the middle bar, 32 who had no post-op vertical deviation and had no pre-op vertical deviation. And so what this study showed us was that some of it is self-correcting. So you might start off with a little vertical, either hypo or hyper, that then improves after the superior rectus transposition. But in the majority of patients, the vertical issue essentially wasn't terribly relevant. In those patients requiring surgical treatment of the vertical, postoperatively, then the vertical could be addressed. So it's not ideal to have to go back and treat the vertical, but it can be addressed. And this is another interesting elaboration on this technique that has been spearheaded by my colleague Linda Doggy. She and our former fellow, Dr. El Husseini, published this article looking at utilizing 3 sutures as part of the loop myopexy and assessing torsion intraoperatively based on where these sutures are placed. And this can then allow for modification if it appears that by doing the loop myopexy, too much torsion is created. I'd like to finish my comments about surgical management of sixth nerve palsy by talking about the Nishida procedure, because this is a procedure that our group is increasingly exploring. And the procedure was initially described by Dr. Nishida in 2003 and updated in 2013. In 2003, it was described as a procedure in which the vertical rectus muscle is split and just the belly is transposed between the superior and lateral rectus muscle, between the inferior and lateral rectus muscle. And the modified Nishida, which the update in 2013, was that these authors found that the vertical rectus muscle didn't even need to be split, but just by transposing the belly of the vertical rectus muscle alone, they could have a very successful outcome. So the modified Nishida, which many are doing now and exploring in our practice, appears to address approximately 24 to 36 prism diopters of esotropia. And then in this 2013 paper, the authors found that when coupled with medial rectus recession, the effect can be augmented up to 50 to 62 prism diopters of esotropia. In the figure below, so the top figure shows where the sutures are placed, and you see that there's a knot around kind of the third, a little bit of a third of the vertical rectus muscle that's then going to be transposed towards the lateral rectus. In the bottom figure, it's a modification that I found really nice and relevant to the procedure that I had been performing for sixth nerve palsy. In this procedure, the authors explore, okay, well, if you've done a superior rectus transposition, such as how I might do it, and have some residual esotropia, can you then perform Nishida procedure on the inferior rectus belly? So in this image in lower right on your slide, you see that the superior rectus has already been transposed along the spiral of Talot, and now the inferior rectus belly has been transposed as per the Nishida protocol. And these authors found in their small case series that improved the residual esotropia up to 25 prism diopters, which I think is quite remarkable. And there are times where we've done what we thought was maximal surgery with our superior rectus transposition and medial rectus recession. And I found that this would be a nice technique for me, having had these patients who'd had the other procedure in the past, if I have a residual esotropia. To summarize, there are numerous surgical approaches to the management of a complete sixth nerve palsy, and this may include some transposition of the vertical rectus muscles and coupled with recession or reduced tension on the medial rectus muscle. When we do vertical rectus transposition using our technique, it appears that the impact on torsion and the creation of subsequent vertical misalignment is minimal and can be addressed surgically if needed. So let's conclude our discussion by considering fourth nerve palsy. The final case is a 14-year-old girl whom I've been following. She has a mild chin-up posture and diplopia in right gaze. Her afferent function is totally normal. In primary position, she's fairly well controlled. She has a left hyperphoria of about 2. And when she looks in right gaze, she becomes tropic. She has a left hypertropia of 10. And up and to the right, you can see that inferior oblique overaction. Down and to the right, you can see the superior oblique underaction. Her fourth nerve palsy was known since infancy, and in truth, although she has some diplopia in right gaze, overall she is not symptomatic, and we have opted to observe her for now. When we think of fourth nerve palsy, we see many children who present with torticollis and congenital fourth nerve palsy. The fourth cranial nerve is very susceptible to trauma, so traumatic fourth is something we see frequently. We also need to look for tumor along the pathway of the fourth nerve that often can be missed when you do a non-contrast MRI. So if this is something you're considering, your MRI of the brain and orbits should be with and without contrast. I see fourth nerve palsies quite often after surgical treatment of brainstem tumors. We've seen it in the setting of inflammatory conditions and also meningitis. In an acute fourth nerve palsy, we will get MRI of the brain and orbits with and without contrast. And it's important to consider potential mimickers such as myasthenia gravis and even thyroid eye disease. Finally, in terms of principles of surgical management, these details have been covered in session 9 on vertical strabismus, so we won't go into detail here. Thank you so much. It's been really a pleasure to speak with you.
Well, thank you, Dr. Heidary. That was wonderful. That was thorough and as complete as I expected, and I think everybody will find that very useful. I have, if I may, just two questions. One technical and the other perhaps a little more conceptual. When doing the Nishida type transposition, let's say we're talking about the superior rectus right now, how extensively do you have to cut back along the nasal border of the superior rectus in order to allow it to pull? Do you do a very thorough dissection there, leave the check ligaments alone? Well, how do you handle that?
I think that's a great question that I've been asking my colleagues as well. I don't think there's a perfect answer. My feeling about this, because I don't think it was described carefully, is that I should approach it the same way I do the superior rectus transposition, where I do a really thorough cleaning of the muscle before I do the transposition, and I detach it from overlying, eyelid, and also just making sure it's not at all adherent to the superior oblique. What has been your experience? Because I that's how I approach it, but I don't know that it's been really carefully delineated that that's necessary.
Well, this procedure really became popularized after I retired from doing surgery, so I don't have much firsthand experience. But when I was doing, let's say, something similar with transposing the superior rectus or inferior rectus without disinserting it, I always did a fairly thorough dissection along the nasal border. It just seemed to me that should be necessary, but I never did it any other way. So
I think, well, I agree with you, but I'm yet to sort of discover any data one way or the other.
correct. The other question I have, you did such a thorough job of how to work up the different cranial nerve palsies when they're acute. One scenario which certainly seemed very common in my practice is the patient who clearly has a superior oblique palsy. Let's say, for the sake of discussion, the diagnosis is not in question. Maybe it's an older child, a teenager, or an adult. And we know it's been long-standing, but we don't know that it's congenital. They may have had a head tilt, but we don't know if they had it when they were very young. We can look at old photographs, but maybe they're inconclusive. And there are no other obvious risk factors, no history of head injury, motor vehicle accident, no obvious accompanying medical issues that might be causative. When and how do you work those patients up?
Gosh, it seems like a straightforward question, but I think it's often a case-by-case discussion. I think, when the vertical fusion amplitudes are high and we see facial asymmetry and we can see the old photos where the head tilt is present, quite often I'm having a discussion with the family or adult that I presume that this is congenital. I can't prove it. And we have some discussion of whether or not to pursue further workup, including, neuroimaging. In some cases, I say, I feel convinced enough that we don't need to pursue the neuroimaging. And in other cases that if it's equivocal in any way, I think it's safer to go ahead and do it. But I think it's more case by case. Most often I find that for the scenario you've described, we feel so confident that it's congenital that I haven't always pursued the MRI of the brain in orbits. I approach these paralytic strabismus in the same way, for me, I was taught if you have optic atrophy that you can't explain the etiology or onset, you need to image. And it's probably safer to go ahead if you have those resources available to get the imaging. And in particular, if you are going to do the neuroimaging, I tried to emphasize that I would do it with and without contrast, because you can definitely miss tumors along the pathway of the fourth nerve if you do it a non-contrast scan.
Well, thank you. I think that's a very practical and wise answer, and I think that's a good note on which we can close. So again, I thank you for this wonderful talk. I thank all the viewers for their attention. If you enjoyed this, which I'm sure you did, I hope you'll tune in and watch all of the other lectures in this series. And until then, I'd like to wish you all a good night, good afternoon, good morning, depending on what time of day and what part of the world you're watching from. Till we meet again.
In bringing you this video course, there are many thank yous. Thank you for viewing the video course on strabismus. We hope you found it stimulating and educational, and that you share its insight with others. We at One World, One Vision extend our heartfelt thanks to the lecturers who shared their years of study to make the video course worthwhile. And of course, to Bert Kushner for taking on the burden, happily we hope, of development and moderating. We also thank the Board of Directors for their continued guidance. We thank our donors for their financial support that made this video course possible. An enormous thank you to the video team of Sweet Sadie for their extraordinary efforts to make the course both visually and auditorially extraordinary, and for their technical guidance of lecturers. Thank you, Rachel, Tim, Eddie, and Bill. If you are interested in learning more about what we do, go to our website, www.oneworldonevision.org. And finally, if you have comments or thoughts or ideas, you can email me at owov2020@gmail.com. Goodbye.